the women in your audience should advocate for and ask their doctor for is I don't only want you to test my glucose level, I want you to test the level of insulin in my bloodstream. Do what's called a fasting insulin level. So when you haven't eaten for 8 to 12 hours, they draw your blood, they check the insulin. It's a very inexpensive test. It's easy to do. Any lab can do it. And you'll now see decades before the blood sugar is high, your insulin level being high. And high is anything in double digits. If your insulin level is above 10 when you haven't eaten for 8 to 12 hours, you are on your way to insulin resistance, or you might already be insulin resistant.
All right. Well, it's a real pleasure to have Dr. Philip Ovadia on the show today. Welcome.
Hi, Zora. Great to be here with you.
So I have a lot of questions. You are a board-certified heart surgeon. You're not a cardiologist. Is that correct? Because yep. I remember reading out your book, Stay Off My Kitchen Table, and I remember you making that clear distinction. But it doesn't mean, I don't know if you have, maybe you should first explain how those two professions may approach cardiovascular health differently, if at all.
Yeah, they're really a continuum and sort of a partnership in how we manage cardiovascular health. The cardiologist, honestly, typically is going to be doing more of the initial management. Cardiologist, besides using medications and things like that, can put stents in and do sort of less invasive procedures regarding heart health. And then when it maybe gets beyond that point, that's when the cardiac surgeons like myself will usually get involved. And the most common, so we do operations, and we used to call them open heart surgery. In reality today, a lot of this stuff can be done minimally invasive, but the most common operation that most heart surgeons do is what's called a coronary artery bypass. And what that means is that when you have blockages in the arteries of the heart that are causing problems, and they're usually kind of too complex or too numerous blockages to deal with a stent, that's when we're going in to do a bypass procedure where we're basically rerouting the blood around the blockage. So this is a pretty big surgical procedure. It carries with it certain risks. It also carries with it the potential for great benefit, and it's a very common operation done. And that's the majority of what I've done for the past 30 years as a heart surgeon. We do some other things. We replace heart valves. We might do other types of operations on the heart and even on the lungs. But coronary artery bypass, the colloquial term for it is CABG. People will hear talked about. We're not talking about the plant stuff that you eat. It's just CABG is the acronym for what we do. And like I said, I've been doing that for 30 years. Now, what changed about 10 years ago was I came to recognize that I really shouldn't need to do these operations. Most of the people that were ending up on my operating table shouldn't have gotten there. Heart disease is largely preventable, and we do a very lousy job. And when I say we, I mean the cardiologist and the cardiac surgeons and all the other doctors that get involved in heart disease at preventing heart disease. We do a great job at treating it. If you have a heart attack, if you develop heart disease, you're much better off today than you would have been 30, 40, 50 years ago. But we really have made essentially zero progress at preventing the disease from getting to that point. And that's what I've really become increasingly focused on over the past 10 years.
Well, you chose a profession that has a lot of patients and a lot of work to do because, and I think up to now, I read that you've done over 3,000 operations now. And sadly, it seems to be still increasing, and you are not having a lack of patients. People are still having heart disease. It's the number one killer of both men and women out of all the diseases of aging, and it's pretty sad that it has come to this. And a lot of women I meet are not quite aware of this. When they think about heart attacks, they think of an overweight man, but yet they would be concerned maybe about breast cancer, but in fact, the deaths from heart attacks and stroke are much higher than they are for breast cancer. So why aren't we focusing enough attention on that? And that's why I have people like you coming on to stress the importance of taking care of our cardiovascular health. And I always say that menopause is such an opportunity. It's like one of the best opportunities we have to protect our future 80-year-old self, because heart attacks don't just start, or heart disease doesn't start when you're 70 or 80. It starts decades before, right?
Yeah, very correct. Women, traditionally, the impact of heart disease on women has been under-recognized. You're correct that it was viewed as a disease that only affected men for a long period of time. And in reality, what we see is that women are somewhat protected from heart disease when they are premenopausal. Estrogen, in particular, is thought to be sort of protective of our blood vessel health. But once women cross into menopause, their risk of developing heart disease equals that of men. And in a lot of ways, women have worse outcomes when it comes to heart disease because they tend to get diagnosed later in the process. And oftentimes, the early symptoms that are classically present in men don't present in the same way in women, and therefore the diagnosis can be missed. But the reality is, as you said, heart disease is the number one killer of women, and I believe that applies to women of any age above 40, essentially. And certainly women that are in that perimenopausal and menopausal age range, their number one risk is heart disease, and therefore that should be their number one focus.
So at what age are you seeing women on your operating table?
Yeah, the unfortunate thing that I have noticed throughout my career, and listen, we're only talking about 30 years, we're not talking about generations here, there has been a very noticeable shift in the age that people are presenting with heart disease. When I was going through my training 30 years ago, we operated on 70 and 80-year-old people, women and men. And we'd have some 60-year-olds, and the 50-year-olds were pretty rare. Today, I am routinely operating on 40-year-olds, and I even see some 30-year-old women on my table. My first book, Stay Off My Operating Table, I open with the story of an unfortunate woman in her late 30s who ended up on my operating table with a devastating and ultimately unfixable condition. And she was a young mother that was lost because of something that really should have been prevented. And that was one of the landmark events, I would say, in my career that really got me thinking more and more about, I do what I can as a surgeon once people are on my operating table, but what can I do to keep them off of my operating table?
Yeah, you had a brutal job. I can't imagine. I've had 2 hip replacements, and I know how impressive it is to see that operating table. It's like a Frankenstein movie, and you're like, oh my God, that's going to be for me. But you see this every single day, and you put people on that table, cut them apart. It's mind-blowing, and I just can't imagine what it must be like to be in your shoes. But you have your own story, and I imagine I'd love for you to share briefly what got you shifting in your mindset in terms of what can I do to help people better?
Yeah, so that shift in mindset really occurred with the realization, again, going back now a little bit more than 10 years now, that I was headed for my own operating table, so to speak. I was morbidly obese. I was pre-diabetic. I was following that same path that so many of my patients had gone down. And what I realized was I didn't know what to do about it. The advice that I had been taught to give them, right? The advice that so many of us have heard throughout our lives, eat less, move more, eat a low-fat diet. It wasn't working for me. It wasn't working for them. And that really started me down a path of asking some different questions and ultimately coming across some different information. And ultimately, I had great success in reversing my health trajectory. I was able to lose 100 pounds. I was able to reverse my prediabetes. And it really got me wondering why I had to go sort of outside the mainstream medical information environment to find these answers, and why what I kind of learned worked for myself, and then I started seeing it work for other people. I would give advice to friends and family at first, and then my patients, and it was very actually counter all of the information that I had learned about what causes heart disease in particular, what causes poor health more broadly. And again, that's really what started me down this pathway. And the first thing that it kind of opened my eyes to was there was a pathway for us to prevent heart disease better than we are doing. And that was one that I couldn't ignore. As a surgeon, it would have been easy for me to just saying, keep doing what I was doing. I had a very comfortable life as a surgeon, very busy, like you said. There's certainly no shortage of patients. But when I really recognized that the best care that I could provide for any patient was to keep them off the operating table, as a physician, right? That's my ultimate calling, to do what I can do best for that patient. And so that's why I have largely shifted towards keeping people off the operating table.
So you had this moment where you felt like, I'm going to be on my own operating table, and that's scary. And did you ever think about a moment where you thought, well, wait, I'm morbidly obese. Can I continue to work? Like, how can I work on somebody else's own life if I'm morbidly obese in the sense that maybe you are physically capable, and I could be totally wrong, but if there are things or consequences other than just weight that come with being that morbidly obese.
Yeah, it hadn't really come to that point per se for me. I mean, it certainly would have, right? Because we do know what starts happening when you're chronically overweight and obese, and you start getting into things like joint problems that, can certainly affect your ability to do something like a heart surgery. Not to mention what I now recognize, right? Things like the brain fog and those types of effects that honestly, when I look back, I realize I wasn't at my best. I can say today, even though I'm 10, 15 years older, I perform much better in the operating room today than I did back then because I am now optimized from a health standpoint. I am what we call metabolically healthy. I don't have brain fog. I don't get tired as easily. I think back to I would finish up an operation back then and I'd have to go to my office and take a nap and have the 3 cups of coffee to get through the rest of my day. And today, that is not the case. I have endless energy now, not only being a surgeon, running my own business, a telemedicine practice, writing books, doing podcasts, all the things that I do. And I just have much better energy today to be able to do all that. And I know that I am much better able to be there for my patients than I honestly was back then.
Yeah, it's a high performance job. You need focus, energy, stamina. And I'm so proud of you for actually getting to where you're at now and obviously still helping people who do need it, and both sides, on the table and off the table. One question I'm just really curious, and it's maybe a little off topic, is in surgery today, because you are still practicing, how have robotics changed the way you do surgery?
Yeah, so robotics have become a part of what we do with bypass surgery. In some cases, it's applicable to do cases robotically and therefore do it less invasively, which can make the recovery period easier for patients. It hasn't become like the main thing. The vast majority of heart surgeries are still done non-robotically, but there are some applications where the robot can be used.
Okay. I think it's super interesting how things are developing with robotics and AI and medicine. And I think, at least so far, so it's been pretty positive in many ways and more accurate in some ways as well. But I'm wondering, let's go to some of the where heart disease really begins. And what does that even mean? Because the first thing people think of, clogged arteries and cholesterol. So maybe we've got to back up a little bit and say, what is the timeline? And as I understand, plaque builds up even in babies or younger people as well.
And this is probably going to be the key takeaway that I want the women in your audience to understand. You are correct. We have been led to believe that it is a gradual buildup of plaque in the arteries that causes, the condition is called atherosclerotic heart disease, right? And it means basically buildup of plaque in the arteries. And that buildup can block off arteries and cause things like heart attacks. So that part of it is true. Now, the part that we've gotten kind of wrong is, yes, there is cholesterol in these plaques, but it is not the cholesterol that is causing the disease. Cholesterol is sort of a bystander that has taken the blame. Many people liken it to every time there's a house on fire, right, there are firemen there. And if you didn't know, you might observe that and say, well, these firemen must be causing the fires. But they're actually there to put the fire out. And in a lot of ways, cholesterol is there to try and heal damage that has been done to the arteries. And if we really want to get to the root cause, and we really want to have the best chance of preventing the disease, the question we should be asking is, what damages the arteries in the first place? And this is what leads us to the concepts of metabolic health. Insulin resistance is the medical term that we talk about, and inflammation is the other primary contributor to heart disease. So unfortunately, we've gotten distracted by the cholesterol, right? And it's very easy to understand why. If we go back to the early days of studying heart disease, right? People died of heart disease and doctors would do autopsies on them, and they would open up the arteries of the heart and they would see this plaque, and in the plaque they saw cholesterol. And then they said, okay, there's cholesterol in some of the foods that we eat, and there's cholesterol floating around in our bloodstream. And we started measuring people's cholesterol, and we noticed broadly that when people had higher, very high levels of cholesterol in their bloodstream, they seemed to get heart disease more. So it became this sort of logical leap of we eat foods that are high in cholesterol, that then causes our blood cholesterol levels to increase, and those increased blood cholesterol levels then cause this plaque to form. Now, it turns out that when you actually put that under scientific scrutiny, there's a couple of problems that come up. Number one is the relationship between the cholesterol that we eat and our blood cholesterol levels is very variable. It doesn't necessarily follow that if you eat more cholesterol, you're going to have higher blood cholesterol levels. And then the relationship between blood cholesterol levels and the development of heart attacks or heart disease more broadly is also very variable. It's a coin toss. There were studies that were done, and these go back to the 1960s, 1970s, that they would look at patients that come into the hospital with a heart attack, and they would find that about half of them have what were considered to be high cholesterol levels, and half of them didn't. So ultimately, I think what we are now starting to understand is the relationship between cholesterol and heart disease is a secondary one. And what we really need to do, what we really need to shift the conversation towards is what are those primary underlying driving factors? And like I said, insulin resistance and inflammation are the two big ones. And unfortunately, the medical system, the mainstream medical system has not shifted its thinking on this. The mainstream medical thinking is still very focused on cholesterol, doing everything we can to lower cholesterol levels, changing your diet, taking medications, taking increasingly powerful medications now to lower cholesterol levels more and more. But the problem is we've been doing this for 50 years now. The first sort of dietary recommendations that recommended low-fat diets, late 1970s. The medications that lowered cholesterol were developed and became popular through the 1980s and 1990s. And during that time, heart disease has not gotten better. Heart disease has been the number one killer in the U.S. going back to the 1940s. We have made absolutely no progress against it, and it continues to worsen. So if cholesterol was the problem, we would be seeing the solution working, and it's not. And that's one of the things that led me to start asking these different questions.
It's actually mind-blowing to think that 50% of the people who go into the hospital with a heart attack have normal cholesterol levels. That, to me, says, and if it hasn't improved over the last several decades with all the statins that we have and medications and diets and cholesterol-lowering foods, that, yeah, you're right. You would think we would see a decrease in mortalities, because I think that's ultimately what we're concerned about. Like, not a number. We're just chasing a number of cholesterol. I don't care about a number. I want to know I'm not going to have a heart attack. That, to me, is more important than the number. But we keep chasing a number, and this is where it can be very frustrating. So then you mentioned that it's metabolic health, insulin resistance, and inflammation that are causing the atherosclerotic buildup, which could lead to a heart attack. So what is causing these three things? And that's where we want to get to the root cause. Maybe you want to explain a little bit what those could be.
Yeah, and so inflammation, insulin resistance, the primary factor here is our diet and lifestyle. Insulin resistance in particular is driven by the foods that we are eating. And we have seen the incidence of metabolic disease and insulin resistance skyrocket. Ironically, although not ironically, the very changes that were suggested to people's diet to try and lower the cholesterol and combat heart disease makes the insulin resistance worse, because you take fat out of the diet, you put carbohydrates in, and you put processed carbohydrates, right? When anything is low fat, it's no longer like something that has occurred naturally. It's something that's been manipulated to take the fat out, replace it with sugar and processed carbohydrates, and this is exactly what is driving the epidemic of metabolic disease. That's really where we need to start undoing this, right? If we're going to change the course that we're on, we need to address first and foremost the foods that we are eating, and then there are other lifestyle issues that play into this. Your activity, your sleep, your stress, all of that. But it really starts first and foremost with our diets.
Yeah, this is very interesting. I want to ask you, because I remember when I was doing my gerontology master's, and I had a course on the mind-body connection, and we were talking about atherosclerotic buildup. And so the factors that we're talking about, similar to like you were saying, is the diet and the exercise and these things to try to avoid this buildup. But the stress was also a component, and that's how the whole course was the mind-body connection. So I said, look, let's imagine you have like the perfect diet and you're exercising great, but you have a lot of stress in your life. Would that still cause atherosclerotic buildup? What would you say to that?
I would say it certainly can, but it's going to be less likely to, because the mechanisms by which stress contributes to insulin resistance ultimately and damage to the blood vessels are oftentimes kind of we'll say nutrient based, right? So one of the things that stress does is the hormones that get released when we are under stress, they tend to raise our blood sugar levels. And sugar is toxic to the blood vessels, directly toxic to the blood vessels, right? This is one of the ways that stress and insulin resistance end up overlapping. Stress also tends to cause us to make poorer choices in how we eat, right? And this is more of a modern phenomenon, right? But now when most people get stressed, they're going for the sugar. They're going for the junk food because they think it's going to make them feel better, right? It gives them that temporary, maybe dopamine spike that can counteract some of the stress. But over the long run, that's causing problems. And then stress also tends to disrupt things like sleep. Stress tends to make us less likely to go exercise and do these other healthy habits. A lot of people start smoking when they get stressed, right? So all of these things, what's been very interesting about changing my metabolic health, getting metabolically healthy, reversing the insulin resistance that was present, is it changes the way that your brain works. It changes the way that your body reacts to stress. So I still have a very stressful life, right? We talked about all the things that I do. And on a daily basis, I literally am holding people's lives in my hands. But it's amazing the difference in how that stress affects me now, how I react to it. My overall mind frame is much more stable, and those stresses don't have those same effects that they used to. And this is something that I see in plenty of my patients and plenty of people that go on a path towards improving their metabolic health. It's not like the primary thing, the reason they do it, but they just sort of wake up a few months later and they're like, oh, I'm not really that stressed anymore. There is actually a very growing field of metabolic psychiatry. And there is some amazing work being done in that field by doctors like Chris Palmer and others. And they have now demonstrated amazing improvements in diagnosed psychiatric conditions like depression, like schizophrenia, like bipolar disorder, just by changing the food that people are eating.
Yeah, well, there's the mind-gut connection, the brain-gut connection, or
exactly.
brain-gut axis that absolutely works two ways. But it's interesting when I asked that question to my professor at the time, and he said yes, it does have an impact. It just blew my mind. I thought, oh well, I could offset stress with having a good diet and lifestyle. But like you explained, it's the stress hormones that get released and the cortisol and all that stuff. It makes an impact, and you could see it if anybody wears a continuous glucose monitor. We'll see that they may not eat anything. They could be fasting, but if they have some stressor that they're reacting to, your blood sugar will go up. And that's what you're talking about, insulin resistance and the metabolic flexibility here, or the metabolic resistance actually is having an effect. So it is mind-blowing actually how this all works together. But it does tie it all together in terms of the blood sugar as well. And that's where the one other point I wanted to make that you mentioned as well, and I want to reiterate that, it's not the stress, it's the perception of stress and your reaction to it is what really matters, because you think those people going through wars right now, talk about stress, and they have to work really hard to manage that, and they have a real stressor here. But managing that is super key to having good heart health. And I would like you to just run off some of the biggest risk factors for heart disease. And some of them you've mentioned. I mean, we know that age is one of the biggest risk factor for all diseases of aging. But what about the other risk factors?
I always like referring to a study that, is very relevant to your audience, the Women's Health Initiative study. And this has been a very large, very comprehensive study looking at many different aspects of health. But, they have had a focus on heart disease, and they published some data probably 3 or 4 years ago now. And they looked at the impact of various risk factors on women's development of heart disease. And, what they showed, cholesterol, right, that most doctors talk to their patients most about when it comes to heart disease. A woman in that study that had an increased LDL cholesterol level had about a 40% increase in their risk of heart disease when compared to women that didn't. So 1.4x. It's not nothing, but insulin resistance, what we've been talking about, as measured by a lab test that's called LPIR, lipoprotein insulin resistance, patients that had an abnormal LPIR score had a 600% increase in their risk of heart disease. 6x, right?
Wow.
So a much larger impact from insulin resistance than increased cholesterol. And that leads you to say, well, why, when I go to my doctor They're typically going to spend 90% of the visit focused on my cholesterol. And many women in your audience, many people, have never heard of insulin resistance. No doctor has tested them for it. No doctor has mentioned it to them. And that is a big one. That is the big one, right? Inflammation, like I mentioned as well. And in that study, inflammation was actually a bigger risk factor than the raised cholesterol was either. And these two things largely get ignored because the focus of the medical system has been on cholesterol. And unfortunately, the way that I view it is doctors have really been handicapped because they've only been taught about the cholesterol aspect. When I was going through medical school in the 1990s and doing my training to become a heart surgeon, I was told that cholesterol was the cause of heart disease. It was communicated to me as this is a proven fact that cannot and should not be questioned. It's ironic, as I was going through my training and I was deciding what area of surgery I wanted to specialize in, and when I told my mentors that I wanted to go into heart surgery, they told me not to do it. They said, there's going to be nothing for you to do in 20 years. We have figured out what causes heart disease. We have these medications. Statins were rising to prominence at that time. And the thinking was, heart disease is going to be wiped out and there's going to be nothing for you to do. And here we are, of course, as we've been talking about 25 years later, I'm busier than ever. There is actually a shortage of heart surgeons in this country. There aren't enough to do all the surgery that needs to be done. And as we've mentioned, heart disease, not only has it not gotten better, but it's actually gotten worse during that time.
So let's back up quickly about insulin resistance, because maybe some people don't even know what that is. So What is it and how does somebody know if they have it?
Yeah, again, to take it even back a step, right? People know about blood sugar levels. That is something that your doctor is commonly testing for. And the reason that we worry about the level of sugar, glucose, right, in your bloodstream is because we know that too much sugar in the bloodstream is toxic. It's toxic to the blood vessels in the heart. It's toxic to many different organs, and it can cause lots of different problems. So insulin is a hormone that our body makes whenever the sugar in our blood, the level of sugar in our blood starts to increase because we want to get that sugar out of the bloodstream as quickly as possible. And the two primary ways that we get it out of the bloodstream are either we burn it for energy through our activity, or we put it into storage. And we can put it into, a little bit can go into the muscle tissue, a little bit can go into the liver. Most of it ends up going into fat cells. That's how we get the sugar out of our bloodstream. So every time your blood sugar goes up, your insulin goes up. And if your blood sugar is going up on too frequent a basis and it's staying high, and again, this ties back to because of the foods that you're eating, and your insulin level, therefore, is staying chronically high, the cells stop responding to the insulin, right? Your fat cells in particular start saying, well, we don't have room for more sugar, so we're just going to ignore the insulin. And your body gets into the cycle where it then makes more and more insulin, right? It's kind of yelling louder and louder to get the cells to listen. And ultimately that reaches a breaking point where the cells just can't listen any longer. And now your blood sugar stays up. And now you get diagnosed with something like diabetes, right? But during all that time, and this is a decades-long process, damage is being done to your blood vessels. So very simple test that, the women in your audience should advocate for and ask their doctor for is I don't only want you to test my glucose level, I want you to test the level of insulin in my bloodstream. Do what's called a fasting insulin level. So when you haven't eaten for 8 to 12 hours, they draw your blood, they check the insulin. It's a very inexpensive test. It's easy to do. Any lab can do it. And you'll now see decades before the blood sugar is high, your insulin level being high. And high is anything in double digits. If your insulin level is above 10 when you haven't eaten for 8 to 12 hours, you are on your way to insulin resistance, or you might already be insulin resistant.
And so fasting glucose, fasting insulin, what about HbA1c and HOMA-IR? Are those
your hemoglobin A1C kind of gives you an idea of what your blood sugar is doing on average over about a 3-month period. But again, this is still a lagging indicator. By the time that number is raised, you've been insulin resistant for a long period of time. The HOMA-IR is a calculation that we can do based on your fasting glucose and your fasting insulin level to inform you whether or not you are insulin resistant. It's one of the ways that we measure insulin resistance. I mentioned another one, which is a little bit more of a complicated blood work called the LPIR score, the lipoprotein insulin resistance score. That's another one that, we can get. But really just starting with the fasting insulin is a good way to start. Now, even before you get the blood work done, there are some other ways that women can get a sense of whether or not they may be insulin resistant. We have 5 basic measures of metabolic health that every woman, every man, but every woman in your audience should know. 2 of them you don't need your doctor for. Okay? You have your waist circumference. Just get the tape measure out, measure above your belly button first thing in the morning. For women, if it is above 35 inches, that's an indicator that you are probably insulin resistant. I also tell women it really should be less than half of your height. So, you can use that as a ballpark. Your blood pressure.
In inches or centimeters?
In inches. So
okay.
35 inches or below is what you want your waist circumference to be. Blood pressure is measurement number 2. And again, you can check this at home these days. You can go to just about any grocery store or pharmacy. They have the little kiosk there. If your blood pressure is over 130 on the top or over 85 on the bottom, that is another indicator of insulin resistance. If you've been started on medication for high blood pressure, that is an indicator that you are likely insulin resistant. And again, most doctors don't make that connection. So those 2 measurements you do at home, or maybe you get them checked at your doctor's office, and then the basic blood work that your doctor has likely done. You want to know that fasting blood glucose level, like we just talked about. So if it is over 100, that's an indicator of insulin resistance. And then the cholesterol panel, but we're not going to look at that LDL cholesterol, which is your doctor is focused on. We're going to look at 2 other numbers on there. Your HDL cholesterol, what many doctors will call the good cholesterol, because we do want it to be higher. And specifically for women, you want it to be above 50. So if that HDL is below 50, another indicator that you are not metabolically healthy. And then finally, the triglycerides, also on that lipid panel, we want these to be less than 150. They're over 150. Another indicator that you're metabolically unhealthy. So you can do those 5 basic metrics, and that will, if 2 or more of those are abnormal, you are likely insulin resistant, and you should be asking your doctor for further testing to confirm that you are, and then you should be asking your doctor, what can I do about this? And if your doctor doesn't know the answer to that, might be time to find another doctor.
So I see how all these things tie in: insulin resistance, the way you explained it, the metabolic health, what those 5 measures showing if you're metabolically healthy or not. And part of that is, well, if you've got insulin resistance, those markers are going to be off the charts. And then the inflammation, because there's inflammation from, like you said, there's maybe the things we eat in our diet and lifestyle. And when we're going through menopause, one, we tend to get more insulin resistant. It's with the loss of our estrogen and progesterone and testosterone. And then on top of that, if you have excess weight, extra fat cells are also inflammatory. So I could see how this all works together, but also it can unwind together as well. And that's the good news, is that we can reverse heart disease. Is that correct?
Yeah, well, we can certainly start by reversing insulin resistance, right? And we know that the best way to do this is eliminating the foods that are causing the insulin resistance in the first place, right? So the highly processed carbohydrates, things like vegetable and seed oils, processed food in general. So my high-level food advice to people out there is eat real food. We need to get back to eating the real food that occurs around us in nature, and not what I now call these near food objects, right, that fill the grocery store, that are not real food. And then lower carbohydrate is better. If you are already insulin resistant, your body is not processing carbohydrates well. So any carbohydrates you eat, even if it's from something like a piece of fruit that most people say, well, this is healthy fruit for me. It's not if you are insulin resistant. Your body can't process that sugar. It's going to put an extra load on, and it needs to work extra hard to then get rid of that sugar. So low carbohydrate, non-processed diets are the best diets to reverse insulin resistance. And once we reverse the insulin resistance, now the inflammation, the damage being done to our blood vessels, that all starts to settle down, and now our bodies can start to heal themselves. And the other thing I want people to understand about insulin resistance is it's not just about heart disease. It's actually about all of the chronic diseases that we worry about, because many forms of cancer, Alzheimer's disease, diabetes, chronic kidney disease, the neuropsychiatric conditions that we talked about earlier. They all come from insulin resistance. So this is what has been even kind of more powerful about this journey, right? Me learning about this is now I'm not only impacting heart disease, right, which is my main focus, but I'm actually helping people impact their overall health. And we're improving all these other conditions along with it.
Okay, I want to go back to the foods and the things that you talked about. But before I do, one last question. I'm going to go back to the testing. What are your thoughts on ApoB and Lp(a) for testing for heart disease?
Yeah, so ApoB, right? So this has become a better way of measuring the cholesterol levels, the cholesterol that might be putting us at risk for heart disease. So I said early on, we had a problem. We started measuring what was called LDL, low-density lipoproteins. These are certain particles that transport cholesterol around in our bloodstream. And that was the original marker associated with heart disease. But I alluded to earlier, it's not that good a marker. It's kind of a 50-50 shot. So ApoB has come along, and ApoB is a little bit better of a marker. And I'll try not to get too technical here, but what ApoB is measuring is LDL cholesterol particles, and it's also measuring something called VLDL cholesterol particles. Now, the thing is that not all LDL cholesterol is the same. Broadly speaking, we have two types of LDL cholesterol that occurs in our bodies. We have what are called small, dense LDL particles, and we have what are called large, buoyant LDL particles. And it turns out that the small, dense LDL particles, these are problematic. These are what we call atherogenic. But the large LDL particles are not. They're actually not problematic. They've just kind of gotten lumped in this classification as LDL. And this is the problem with measuring LDL alone or measuring ApoB alone, because you're going to measure all of those LDL particles. And what you don't know is, okay, you have what's considered to be a lot of LDL or ApoB around, but you don't know, is it truly the bad kind or is it not? And it turns out this brings us right back to insulin resistance, because when you are insulin resistant, what happens is the types of particles that you have shifts, and you end up with more of those small LDLs, and you end up with more of those VLDLs that are truly problematic. Mm-hmm. But when you're metabolically healthy, you may have a lot of LDL around, but it may be mostly the large LDL that is not problematic, and therefore the fact that your LDL level is high is not causing you any problems and does not need to be treated and does not need to be addressed. So this is where we get into some of the confusion around cholesterol, right? More broadly, doctors just want to say, well, cholesterol is bad, LDL cholesterol is bad, and everyone with a raised LDL level needs to lower it.
Well, that makes sense to understand the particle size and if they're large and fluffy and buoyant, or if they're hard and they're actually causing, those are the ones that are causing the damage. So then it's not that, oh, we should just ignore our LDL levels. Who cares? It's more like, let's take a deeper dive and let's see, and then look at the whole picture. If you are metabolically healthy and yet have these large fluffy ones, you should technically be okay and not worry about atherosclerotic buildup. Is that true?
That is true. And I mentioned insulin resistance and inflammation, two eyes. There's a third eye that I think is important for people to be paying attention to when it comes to heart disease. And this is imaging. Because up until now, we've been talking about blood work, right? And we've been talking about things that may or may not predict your risk of heart disease. But we today actually have the technology available that I can measure how much atherosclerotic heart disease you have, non-invasively, with imaging, with CT scans. And I draw the parallel when I talk about this to the mammogram. We would never tell a woman today, don't get a mammogram. When you have a palpable lump in your breast or when you have obvious breast cancer, we'll deal with it. But that's essentially what we do in heart disease. We say when you start getting symptoms of heart disease, when you have a heart attack, we'll worry about it, instead of saying, let's look early and see if there's actually plaque developing in your arteries. So using imaging and the starter test that I tell, again, all women by the time you're 50, ask your doctor, I want a coronary artery calcium scan, it's called, a CAC scan. It is a very simple, inexpensive test to do. You go to an imaging center, you lay down on the CAT scan table, they don't have to put an IV in you, it literally takes 5 minutes, and you will start to see how much plaque, specifically how much calcified plaque, is building up in the arteries of my heart. And depending on the results of that, you might want to get a more advanced scan. It's called a CT angiogram. This can show us finer detail in the blood vessels, but at least get the CAC scan. So now we know we're not worried about indirect measures that may be indicators of your risk of heart disease. We're actually measuring how much heart disease do you have, and we can now track this over time, and we can start to see, is it getting worse, is it getting better? And as you start to do things like reversing insulin resistance, can we stop that plaque from getting worse? These are the things that we really should be focusing on more and more when it comes to heart disease.
Oh, yeah. I love testing, measuring, and assessing. I always think, like, let's look under the hood. But as I understand, and correct me if I'm wrong, there are people who can have a 0 calcium score, which is like perfect. You don't have any plaque, but yet have plenty of plaque buildup. There's some error in that scan, isn't there?
Yeah, it's actually pretty rare. Yes, it does occur, but it's not a common occurrence. You can have what is called soft plaque, non-calcified plaque building up in your arteries. But it turns out with a CAC score of 0 at a reasonable age, right? So when we're talking 50s and 60s, if you have a CAC score of 0, your chance of having a heart attack over the subsequent 10 years is less than 1%. So there are rare cases that can be occurring, but it is a good enough screening test, right? No test is 100%. Mammograms miss breast cancer and mammograms overcall breast cancer, right? But the CAC scan is as good as we get in assessing heart disease at its early stages and then being able to follow the progression of it.
Then what's your thought on, as I understand, you have the CAC scan, and then you have, like you mentioned, if you need to go deeper, then you have a CT scan. And then there's the AI technology called Clearly or Carry Heart. And this is where you take your CT scan and you plug it into the algorithm, and they can see the percentage of block, if it's hard plaque or soft plaque. And to me, that sounds like, wow, that's the ultimate. That's the gold standard. I guess you couldn't get more advanced than that, or not.
Yeah, no, I agree. It is the ultimate, and it is a test I use a lot today with my patients. Now, there are drawbacks, right? Doing that type of scan, the CT angiogram, and then the AI analysis on top of it. But doing the CT angiogram, it's more complex. It's more expensive. We have to put an IV in and give you dye through that IV, and the radiation exposure is higher than the CAC scan. So it is a great test. I am very optimistic that as the technology continues to improve, we will be doing this more and more, and that is really going to give us the most powerful tool on seeing how much disease someone has, seeing how that disease changes over time, and then we can start asking questions like, well, if there are people that have high cholesterol levels, but their plaque isn't getting worse, what does that mean? And it starts to really unpack a lot of this for us. And those are the types of studies that we're starting to see done. And that's giving us a better understanding about what are the true risk factors and what are things that maybe don't predict risk as much as we thought they would.
Okay, so technology is moving very quickly. I'm thinking about the women that I attract to my community in general, pretty active, actually. They're quite healthy. They're into health optimization. They want to biohack the next level. And many of them, of course, they're all going through perimenopause or just postmenopause. Many of them have heart disease, have high cholesterol or poor ApoB scores, and they're really worried. And I'm wondering, and some of them even are hyper responders to saturated fats, for example, or their genetics show them that. So What is going on here? Because these women are quite healthy, you would think, but yet some of the markers of the blood tests that you've mentioned are not coming out really good.
So one of the major things that's going on here is our misinterpretation of the blood test, right? This belief that because your LDL or your ApoB is high, you have heart disease or you are at great risk of heart disease is not always true. And if you are not insulin resistant, if you do not have inflammation, high LDL cholesterol does not correlate at all with the risk of heart disease. So a lot of what's going on is misunderstanding by the doctors of what they're looking at and not understanding that nuance about LDL cholesterol and ApoB levels. So that's one thing, right? And this is a perfect situation for a woman in that case to say, well, how about we get a scan and see, do I actually have heart disease or not? And oftentimes you'll find that they don't have heart disease, or they might have a little bit of heart disease that isn't getting worse. Because many women, while they might be healthy today, they weren't always healthy, and there may be some damage in the past that you'll see, but if it's not ongoing active damage, then we're probably in an okay situation. So that's the first thing that women need to push back with their doctors or work with their doctors to help get a better understanding of where they're at. The other thing that, quite frankly, I see comes in here is a lot of the advice about how to be healthy, right? How to live a healthy lifestyle turns out to be the wrong advice, right? And a lot of these women, they've been eating the low-fat foods their whole life, right? They've been eating lots of fruits that may not be helping them if they are insulin resistant. And one thing to understand about insulin resistance for the women in your audience, you don't have to be overweight to be insulin resistant. You can be an athlete and still be insulin resistant. One sort of trap, I guess I'll say, that I see many women fall into, right, is that they are very athletic, but they're fueling their athletic activity with sugar, with carbohydrates. And they're told you have to carb load before you go do cardio. And they might be running marathons, constantly taking the sugar gels to fuel that activity. And that can be causing damage because their body is trying to keep up with this sugar load that's constantly being delivered. And even though they might be working it off because they're exercising, it's still doing the damage. So those are some of the things that I see can occur. And again, it comes from not really recognizing what the root cause problem is, not assessing for things like insulin resistance, and not getting the imaging to see, do we really have heart disease or not?
Yeah, I think sometimes when you talk about pro athletes as well, or marathon runners, there's a lot of inflammation going on.
Yep.
They seem healthy, but in fact, there's doing a lot of damage, and it's a little excessive. Exercise is good, but too much is also not good. And too little is not too good. We need that sweet spot. So I can see how this is where the inflammation place comes in, and maybe even the insulin resistance. And I want to go to what you mentioned before in terms of the diet and clarify a little bit, because when we say low carb diet or no carbs or avoid sugar or avoid fruits, the women that I attract to my community take it a little bit too far. And I think there's no carbs, in fact, when they are quite athletic. And I personally think their hormones are suffering from this as well, because we need carbs for our hormones. But yet, again, it's a sweet spot. Like, what kinds of carbs should we be eating? Because what I'm seeing works really good for the guys. Like, I used to health coach, and I was like, why are the guys like able to do this? And the girls cannot. And they're really struggling with it. And it boiled down to a lot of hormones and menopause and all these things. So maybe let's clarify the woman. And again, you do a good job in your book as well as clarifying there's the women who are insulin resistant, and they clearly need to be a little bit tighter, for at least until they fix this problem. And then there's the woman who's not insulin resistant, and she's athletic, and she just wants to lose some weight, and she's training too hard and eating too little, and carbs are totally out, and she's fasting, and it's just going completely haywire and not giving her the results. So maybe we got to fine tune what we mean when you say carbs.
Yeah, well, the situation that you just alluded to is a problem that I do see in women, but the lack of carbs isn't necessarily what's causing the problem. Now, when someone, women or men, right, are metabolically healthy and they are active, yes, you can tolerate carbohydrate. And of course, you want to stick to the non-processed carbohydrates, right? Things that are coming from vegetables, maybe it's a baked potato, something like that, right? Those foods can be tolerated, but honestly, I don't think they're necessary. For the women in a situation like you just described, they're overtraining and they're under-fueling, right? But that fuel can come from fat just as well, maybe better, than it comes from carbohydrates. And so oftentimes when I'm working with women like that, the answer is, yes, you need to be eating more. You need to be eating more fat, particularly, and maybe more protein. Under-eating protein is another common problem in women. It's not necessarily that you need carbohydrates. Like I said, sometimes you can introduce carbohydrates without problems, but women can do low-carb diets very effectively. But yes, they need to take into consideration their hormones, their cycle if they're premenopausal, right? And what's going on with their hormones if they're peri or postmenopausal. And they may need to do things a little differently than men do them, but that doesn't mean you can't do a low-carb diet as a woman.
Yeah, so what I've seen with the women who I was coaching before, they really missed some of their carbs. Like, they missed fruit and they missed vegetables. So these were quite healthy women, again, just trying to optimize. Yeah. So there's a part where you go, okay, do what I have to do because I have heart disease, or maybe I have insulin resistance or whatever. But once we get generally metabolically healthy, there's the piece of joy in eating the foods that you like to eat, or maybe there's a wedding you're going to, or maybe you're traveling. And so I like metabolic flexibility. I like to eat my carbs, and I like to eat my fats, and I like to eat my proteins, and I like it all to be balanced. And many of the women I work with generally kind of like that too. So it's about trying to, for me, to move them in a space where they get healthy, they get metabolically healthy, but yet there's a little room for the things that they absolutely love. And that makes life worth living sometimes.
Yeah, and that is a very valid approach, right? And in situations like that, right, that can be a great situation where you say, okay, put on a continuous glucose monitor and see what happens. And if you're having the fruit, or even if you're having some dark chocolate, right, and your blood sugar isn't spiking, great. Like you said, you're metabolically flexible and you should feel free to continue to enjoy that stuff. But if you're having the handful of blueberries in the yogurt that maybe has a little too much sugar added to it, and you're seeing your blood sugar spike, right, then that's going to be something that you're not going to want to be doing on a regular basis.
So we do 10 burpees.
Yeah.
After you eat it.
The CGM can be a great tool to help guide people, but you're exactly right. And I talk about in my book, I don't think everyone needs to be on a very low carb and strict low carb diet. I do think everyone needs to be metabolically healthy to start with. And then you can figure out, if you want them, what your sort of tolerance of carbohydrates is going to be. And of course, stick more to the whole real food carbohydrates as opposed to the highly processed carbohydrates. Those are kind of the high level strategies that I use with my patients, and those apply both to women and men. But you're right, women, it can be a little bit more challenging finding that right balance.
And it's a lifestyle thing too. I think what I gathered from your book as well, and your life and the way you eat and your lifestyle too, it's, you got no time. Like, you got to do it quick. You don't want to think too much. You want to make it easy. And of course, who doesn't want that? And so this is where your book can really help some people and guide them. And I'm diet agnostic. Like, I don't care. I've seen all kinds of people thriving on all kinds of diets. So this is what I like. The biohacking pieces, and you figure it out. You figure out what works for you, depending on your goal. Maybe some people are like, I don't care. I'll die someday. I'll have a heart attack. Like, who cares? Like, that's their life. They can do that. They're probably not listening to this podcast anyways.
Exactly.
But I want to share, I think I'm going to have to wrap up here. I could go on forever with you. It's already time up. But if anybody wants to work with you, you're accepting patients. How does that work?
Yeah, so I have a nationwide telemedicine practice. I am licensed in all 50 states and Washington, D.C. We also see international people, but you can find out all about the practice at ifixhearts.com. You can follow me on social media at ifixhearts. And then my new book, Stay Off My Kitchen Table, it's being released July 28th. It's available for pre-order now as we record this. You can go to stayoffmykitchentable.com, or you can go to any of the places that sells books and check that out as well.
Great. I'll have links to all of those in the show notes. And if anybody buys the book, don't forget to leave a review on Amazon. I know for people making books, that's really important.
Yes, thank you.
Wonderful. Well, thank you for your time, Dr. Philip Ovadia. If anybody is listening to the end, please, well, of course you are. Thank you so much for listening. And we wouldn't be here without you, so really appreciate your time. And please reach out to Dr. Ovadia if you have any more questions. So have a good day, good night, good morning, wherever you're at, and we'll see you next time. Take care.